having an alternative therapy such as HVNI is less well established, less well known. And I think these two papers help establish that as a potential new therapy in treating respiratory failure.
This is Velocity from Vapotherm. In this series, we join conversations between researchers, educators, and clinicians to explore topics of respiratory care. Today's episode concerns Mask-Free NIV for COPD patients. You will join emergency physician Dr. Kirk Hinkley as he interviews pulmonologist Dr. Charles Atwood about the latest research concerning use of high-velocity therapy for COPD patients. They will be discussing an article by Dr. Doshi and colleagues that was published in March of 2020 in Heart and Lung. Dr. Atwood breaks down the research and offers his insights as to the clinical practice implications of the results. While this episode does include discussion of Vapotherm's high-velocity therapy as a tool for treating respiratory distress, Vapotherm does not practice medicine or provide medical services or advice. Any recommendations provided herein are solely those of the speaker. Practitioners should refer to the full indications for use and operating instructions before use of any product referenced herein. Dr. Hinkley is an employee of Vapotherm, and Dr. Atwood is a paid consultant of Vapotherm. Now, let's join the conversation.
All right, so today we are going to be interviewing Dr. Charles Atwood, a pulmonologist at UPMC and the VA Medical Center in Pittsburgh. We're going to be talking about the article published in the Heart and Lung, a journal in March of 2020, and that was titled "The Ventilatory Effect of High-Velocity Nasal Insufflation Compared with Non-Invasive Positive Pressure Ventilation in the Treatment of Hypercapnic Respiratory Failure, a Subgroup Analysis." And this is a subgroup analysis off of the base study done by Pratik Doshi out of Memorial Hermann, University of Texas, who is the lead author. There's a reason that we asked Dr. Charlie Atwood to join us today, and that is because Charlie is not just a pulmonologist, he really is a preeminent pulmonologist. He is a past president of NAMDARC, the National Association of Medical Directors for Respiratory Care. So kind of a heavy hitter in the world of pulmonology and sleep medicine. And so thank you, Charlie, for joining us. So before discussing this article, the study is derived again from the Annal Study, which was published in July of 2018. Would you, Charlie, would you be kind enough to review a little bit about the main Doshi study from Annals in 2018?
Yeah, sure. Thanks a lot, Kurt. The study from Pratik Doshi, published in 2018 from the Annals of Emergency Medicine, was an important study in the field of the broad field of high flow therapy. And what they did is they recruited patients from 5 different ER facilities, emergency department facilities, and different hospitals across the southeastern United States. Some of the hospitals were academic, some were more private. They were all kind of, I think, pretty broadly representative of what goes on in emergency departments across the country. They weren't, they were general emergency departments that see a broad range of patients. The patient population in this study were people who came into emergency departments with undifferentiated acute respiratory failure. And they did not pre-select for any certain cause for acute respiratory failure. They really took all comers for the most part. They recruited about 200 patients, a little over 200 patients. And the purpose of the study was to compare high flow nasal insufflation therapy with non-invasive positive pressure ventilation. The non-invasive positive pressure therapy was delivered by Philips Respironics hospital-based bi-level machine, and the HVNI was Vapotherm's precision flow device. The subjects were recruited in the ED, and they received the assigned therapy. The study was was randomized, but it wasn't blinded. It would be essentially impossible to blind this kind of study. And what they were looking for, the outcome measures were primarily ultimate need for intubation for respiratory failure within 72 hours of entering the study. Secondary measures included changes in blood gases, perception of the therapy, and then interestingly, they had a component which allowed for crossover to the other arm of the study if in the mind or the feeling of the ER attending or subsequent attending in the hospital, the patient wasn't doing well with that particular assigned therapy, either the HVNI or the NIPPV. And the main sort of two top line findings of this study were, first of all, that the HVNI was non-inferior to the non-invasive positive pressure ventilation in terms of the intubation outcome. In fact, although there was no statistical difference, there was a trend towards the HVNI patients doing better. They had a lower intubation rate than the NIPPV. So it was about 7% for the high flow or high velocity nasal insufflation therapy, and it was 16% for the NIPPV therapy. That's an important finding. That is really interesting. The secondary analyses, or the secondary outcomes in terms of like change in PCO2 level, change in pH level, did not show a significant difference between the two arms. So the final conclusion of this paper was that high velocity nasal insufflation therapy was not inferior to non-invasive ventilation with a typical bi-level machine for a kind of heterogeneous group of patients with acute respiratory failure. So those are the top line findings for this original 2018 paper, from which Pratik Doshi did this secondary analysis of a particular subgroup that's in this new paper that we'll discuss.
Yeah, and so Charlie, you mentioned that that this was a study done on undifferentiated respiratory failure patients. So that probably included multiple ultimate diagnoses. So what was the purpose? We're talking about this study in heart and lung. What was the purpose of this subgroup analysis for COPD? Why did they think that it was worth studying?
So there's several reasons, I think. One, COPD, in the parent study, COPD was, I think, the largest single group of people enrolled, but by far it was still a minority of the total number of patients enrolled. And I think COPD is a particularly interesting group for this kind of therapy. And I think it's important to take a special look or drill down a little bit deeper into the COPD population of the original study. And that's what they did in the heart and lung paper. It's important because COPD is so prevalent. It's such an important cause of acute respiratory distress and acute respiratory failure for people coming into emergency departments. And it's the one population that I think, if you're going to study one group of this mixed group of patients, it's the one where you from a population basis could make the biggest impact if you have some successful therapy directed towards COPD and acute respiratory failure.
Yeah, and I think in the broader high flow body of research, most of the studies out there are in hypoxic respiratory failure. And so it really kind of opens that door. So what can you tell us about the results?
The findings specifically for COPD are interesting. They also showed both therapies were successful in decreasing the PCO2 and improving the pH. But there was an important difference, I think, in the intubation rate. It was definitely lower in the HVNI group. Why is this important? I think one of the reasons the second Doshi paper is important is because the role of HVNI in hypercapnic COPD patients presenting with respiratory distress has not really been firmly established. Every physician in practicing in ERs or in pulmonary medicine knows that NIPPV is well established for treating that. But having an alternative therapy such as HVNI is less well established, less well known. And I think these two papers help establish that as a potential new therapy in treating respiratory failure in COPD patients.
So in terms of the result, did they show definite changes in PCO2s and
Yeah.
or PHs?
Yeah, pH or PCO2 went down in the COPD group with HVNI. It did go down in NIPPV as well, but it certainly went down in HVNI to at least a comparable amount. Again, the overriding statistical framework of both studies is a non-inferiority study. So we're not trying to show that HVNI is better than NIPPV, but that it's certainly not inferior. And both these studies showed that.
Yeah, so HVNI, a vapotherm system, is an open system. It's nasal cannula based. It is not primarily generating positive pressure. What do you think is the physiologic explanation that led to the device being able to treat these patients with hypercapnic distress?
So I think the mechanism is that the high velocity of the flow generated from the precision flow device is, the air is heavily conditioned and moisturized. It goes through a very small nasal cannula that sits in the nares of the patient, and the velocity of that gas coming through their vestibule and really the rest of the upper airway, the so-called anatomic dead space, where the gas at the end of exhalation is highly enriched with CO2. So it's CO2 rich gas that's being ready to be inhaled on the next inspiratory effort. By flushing out that CO2 rich gas and replacing it with oxygenated gas, you reduce the amount of CO2 that's rebreathed with each subsequent inspiratory effort. And so the patient ends up breathing gas that is much lower in CO2, and therefore over several respiratory cycles, you can really lower the amount of CO2 rebreathing, and hypercapnia can be partially mitigated by that. And that's the mechanism of action of HVNI. And it's great because the fact you don't have to seal the nasal airway with something that occludes it so that pressure can be delivered. By simply delivering gas at a high velocity, you can achieve the same thing that you would get, or actually maybe even better than just using non-invasive ventilation pressure to manipulate that gas mixture.
So these studies looked at treatment failures leading to intubation or leading to crossover. What were the primary reasons for these treatment failures of the different arms?
So in both arms, it was failure to ventilate. So there are just some patients for whom neither therapy is going to be adequate to ventilate them, and those patients are going to need to go on to be intubated. In the case of the non-invasive ventilation group, they crossed over because a large percentage of those patients simply don't feel comfortable having a tight-fitting face mask over their face. And it's uncomfortable, and they did not do well with that therapy. And I think all clinicians who see these patients have seen that kind of patient many times. Interestingly, in terms of like patient tolerance of the therapy, non-invasive ventilation was tolerated only fairly well, but HVNI was tolerated very well. There were no failures for HVNI due to patient intolerance.
Yeah, so certainly BiPAP, CPAP are something that we're quite comfortable with, especially in the emergency department. But regarding the intubation rates, did one arm benefit from the ability to cross over to the other prior to intubation?
If you started out in the HV&I group and you crossed over to the non-invasive ventilation group, your intubation rate was reasonably low. However, the opposite was not true. If you started with the non-invasive ventilation group and you weren't comfortable with it, or for whatever reason you didn't like it, and you crossed over to the HV&I group, then the intubation rate was, I think, at least 50%. So it was higher for going from non-invasive ventilation to HV&I than it was the other way, from HV&I to non-invasive ventilation. So, as like somebody who sees these patients in the ED or in the ICU, I would take from that, if you're going to start with a therapy and you have the choice of these two, you might want to start with HV&I first. And that way, if it doesn't work, you can go to NIPPV. And, that's a reasonable decision-making activity that has some evidence that you might be able to avoid intubation. However, if you start with non-invasive ventilation and they don't tolerate it, going to HV&I is not as likely to help. And those patients are more likely to be intubated.
In terms of failure to ventilate, but were some of those patients able to be rescued and not intubated?
Some patients, especially if you start with HV&I and then you have to go to NIPPV, those patients were salvaged much better than going the salvage in terms of not having to intubate them instead of having to intubate them right away.
Were there any other interesting observations from the study? Length of stays or patient time in high acuity care areas, that sort of thing. Any observations that you made from the study?
So the patient population that received HV&I, they tended to stay in the ICU for a shorter period of time than the NIPPV group. And we also talked a little bit about like tolerance of the therapy. The tolerance of the therapy was better for the HV&I group than the non-invasive ventilation group. I think there's probably several reasons for that. I think mask intolerance is one from the bi-level group versus the nasal cannula group. It's just tolerated better. I think people sometimes persist with non-invasive ventilation longer than they might ought to do. They might ought to just abandon it quicker if it's not really working. But I've seen this many times where people just persist. They think, if we just tweak the pressures a little bit, it can get better. I thought the interesting thing also is that the overall better acceptance of HV&I. I thought people just liked it better. People that are comfortable with therapy may be able to respond to other therapies better as well. If you're not having a mask over a full face mask over your face, participate in communication as well. HV&I tends to avoid all that.
Yeah, and these are non-inferiority studies, and one of the things that I noticed you've said many times through this interview is that the groups were the same, where there was a little bit of difference, and that's important when we're talking about something in comparison to gold standard. Do you have any comments on that?
The gold standard for this would still be non-invasive ventilation. I think that the newer therapy with nasal cannula based high velocity insufflation and flushing out of the nasal vestibule is it's probably not quite experimental still, but it's just not as well known. And being able to give that therapy a try in ERs, in ICUs is still maybe something that's not quite fully there yet.
With regard to COPD and hypercapnia, what do you think are the implications of these results to the clinicians?
I think the implications are that there's a new therapy on the, whether it's on the horizon or actually now readily available in many places. There's another therapy for patients who do not like non-invasive ventilation because they largely don't like the tight-fitting full face mask that they have to wear. We have an alternative now in high velocity nasal insufflation that, at least in this one big parent study and the sub-analysis of that hypercapnic COPD group, is looks pretty promising and may become a real viable therapy in the future.
And so HVNI is a form of high flow nasal cannula. Can we extrapolate these results to any type of high flow nasal cannula device?
I don't know. I mean, I think the Vapotherm device focuses on a very small nasal cannula, and the velocity of the gas, the conditioned gas going into the nasal vest, is really predicated on the fact that velocity has been shown in modeling studies to be a key determinant of how well the upper airway is flushed. The other device on the market really just focuses on delivering bulk flow of gas through a larger nasal cannula. And whether that works as well in flushing out the nasal vestibule, I'm not as sure.
Do you think that this study at least gives the idea that high velocity nasal insufflation is going to be successful in treating hypercapnia?
I think it points pretty strongly in that direction. I think more studies will need to be done to kind of firmly conclude that. I think the the historic role for this kind of therapy is, as we talked about earlier, has been hypoxemia, hypoxemic respiratory failure. You can add oxygen to this conditioned gas mix and deliver incredible amounts of FiO2 to patients who are really hypoxemic, and that's been a tremendous success in taking care of very hypoxemic patients. The ability now to help control hypercapnia in a way that can prevent intubation in people that have respiratory failure more along that type, or type 2 respiratory failure, is pretty exciting. But more testing, I think more studies have to be done to really conclude that.
Yeah, so you use HV9, vapotherm, high velocity nasal insufflation in your practice. What is your experience in terms of treating hypercapnia and COPD?
So my experience would be, I think, along the lines of the studies that Dr. Doshi has published. We use it. I'm an intensive care doctor. I don't really spend any time in the ED, but when patients come up to the ICU, there are many patients for whom now we will initially go with HVNI for the initial respiratory support for these patients. And we haven't kept strict track of outcomes, but my general sense is that it affords a decent chance for the patient not to have to be intubated for the first couple of days that they're in the hospital. We still use a fair amount of NIPPV as well. We have a lot of these patients that come into our ICU. I mean, I practice largely in a veterans hospital, and we see this type of patient literally every couple of weeks. And we're using more and more of the HVNI as the initial respiratory support.
Yeah, so it sounds like you believe that in your practice that HVNI is a good alternative to NIPPV. Is there a stage of COPD or comorbidity that might be better suited to one versus the other?
I think, so I think we don't totally know the answer to that, but I think that COPD patients who have hypercapnic respiratory failure that are not so extreme that their pH is, say, below 7.2, or their PCO2 is not above 90. I think that's a group to try this in. There are clearly patients for whom we just should go to intubation right off the bat. So the most severe patients, I don't think this is the best choice initially. this milder patients who come in, who will always come to our ICU and not go to our medical floors because they're at risk for doing poorly, but they're not as severe as the most severe patients we see. That's a good population. And, in the papers that we've been discussing, the mean PCO2 is around 55 or 56 or so, and the pH was around the low 7.3 range. And there's a lot of patients that get admitted with that, and we see lots of those as well. Someone whose pH is 7.0 and the CO2 is 100, I don't think that's the right patient to start with.
I would encourage you to try it.
I'm always willing to.
I've done a number of things. Of course, I don't have the benefit in the emergency department of knowing what their numbers are. I have to kind of judge for myself their mental status or O2 sats or respiratory rates, their level of stress. And I've been surprised at how sick some of the patients have been number-wise that I was able to treat successfully. So, and I think that that's where comfort and experience with the technology is really, we're still in our infancy, if you will, in regards to that. But not my interview, your interview. So I just want to throw it back to you and see if you have any more comments on the paper or use of HV&I in general or anything else.
Yeah, so I think the two papers we've discussed, the older 2018 paper and the newer one that's just coming out now, is pointing, I think, a road for vapotherm to go down. We know that this therapy has a number of physiologic effects that can benefit a lot of different patients, not just COPD patients, but others. But in terms of the COPD patients, the other thing I like about this therapy is the gas being incredibly super saturated with moisture. You avoid a lot of the drying effect that occurs when regular oxygen is administered at high levels, 6-8 liters per minute with just wall oxygen. It can be incredibly drying. Using this kind of therapy, providing moisture to the upper airway and really then the lower airway, maybe not as well quantified, but I think it really does have benefits. And then we've talked about the effect on CO2, which is beneficial. So there are a lot of good things about this therapy that patients may really benefit from.
Great. And I know that you've had some success lately in having a couple of publications with regard to COVID and treatment of the hypoxic respiratory failure, or even the transmissibility effects and concerns with high flow therapy. So good luck with your work, and thank you for joining us.
Yeah, thanks for having me. It's a pleasure talking with you about all this.